My name is Charu Gupta. I am a cardiologist who specializes in advanced heart failure and transplant, as well as cardio-obstetrics. So cholesterol is one of the many hidden risk factors that we have for developing heart disease. It's something that could be wrong, that you would never have any idea if you're not specifically checking for it. So it's something that, especially in the South Asian community, we need to be a little bit more cognizant of and start screening ourselves earlier and earlier because we have a high risk of coronary artery disease. I think that one thing people don't always realize is that their family history is really, really important when we're discussing cholesterol. If you tell me that you had an uncle or a parent who died in their 30s or 40s and they had coronary artery disease, then that tells me a world about what your genetics might look like and how much of a risk you have. So you could be the healthiest person who's jogging 5 miles a day and think that you're doing everything right and still have a high cholesterol level and be at risk of a heart attack. And you can be somebody who is not all that active and have a very low risk of a heart attack. So it's one of those hidden things that makes it really necessary for people to see a doctor regularly. So generally, a basic lipid panel is more than enough for most patients. This is something your primary care doctor can do every year, every couple of years, usually starting kind of in young adulthood. And we start to do them almost yearly as people get older. If you are started on medications, we tend to repeat those tests within 3 to 6 months to see if there's been an appropriate response and to make sure that we've controlled this risk factor adequately. You know, the American Heart Association and American College of Cardiology has one set of guidelines. The European Society of Cardiology actually has kind of stricter guidelines as far as what our goals are for cholesterol. I would say that the South Asian community specifically, we have very high rates of coronary artery disease, and I think although it's not accounted for in any of the risk calculators, we should probably use some of that background, including family history, to determine how low your cholesterol should be. I don't think that a lot of South Asians are aware, or if they are aware, they're also worried about taking a medication like a statin. They've heard that people get memory issues. They've heard that there could be some muscle aches and pains. And although that's true, if your risk of having a major heart attack or event like a stroke is very high, sometimes we have to discuss and work through some of those symptoms or side effects and see if you're even somebody who would have a side effect. A lot of people don't have any side effects at all. So what I've been doing most recently in my practice is working with women who are pregnant and who have cardiac issues either going into pregnancy or ones who develop hypertension or gestational hypertension or preeclampsia during their pregnancies. And we're trying to do more education for these women about what they can expect later in their lives. So while you are still planning to get pregnant and breastfeeding, and we're not going to be treating your high cholesterol, but it's an opportunity when we see women when they're pregnant for them to also take note of what risks they might have for later in their own life. And I hope, and I usually direct my patients saying, hey, you have an increased risk of heart disease. I think you should get your cholesterol checked when you hit 30. I think you need a primary care doctor to see every few years. And please remember in the future that this is something that you can speak up about and let your doctor know. I was told all these years ago that I have a little bit increased risk and I want to screen for my risk factors. So I think for some women, they're worried that they are putting their own health at risk by not treating their cholesterol at that point. And what we try to tell them is that the risk at that age is so low that it's more of a marker of things we need to look at later in life. When you're in your 30s, 20s, having kids, maybe early 40s, you don't necessarily have all these other risk factors. You haven't developed diabetes type 2, you don't have hypertension. It's later in life when we have multiple things going on that we need to be a lot more aggressive with the cholesterol. So I think knowing what your level is early is great, but it's really what does that number mean in relation to all of your other risk factors. That's what really determines how we manage it. So it's just kind of a little reminder to you, even if we check it when you're young, that hey, this might be something you want to keep an eye on. So I think the issue is that in our current society, a lot of women are having babies later in life, and they've also developed other comorbidities by that time. So for example, more people might be obese, they might have diabetes, they might have high blood pressure, and when you add all of those things together and then you put the body through being pregnant, it's a big undertaking. It can be very stressful, and it does change a woman's body. And for some women, these changes are important for their future health. So there are some people who actually will look at all of their risk factors after having had 1 or 2 children, maybe having preeclampsia once or twice, and say, you know, just knowing my risks from what I've already been through and my family history, I think I'm ready to stop having children and start on my medications and start really focusing on my health. And the benefits of going through another pregnancy or the risks of that are just too high for me. So I think it's important to acknowledge that people have concerns. I don't think it's ever helpful when a doctor just blows off somebody's concerns and says, oh, that's not true, or that never happens. You know, we really have to listen to what patients' impressions are, because that's what's going to determine whether or not they take the medication. And at the end of the day, that's our purpose, is to help them take the things that improve their health. So I think it's important to know what they've heard before, know what their concerns are, and then also check in frequently. Because if something develops, sometimes we have answers for some of those problems or those side effects. Sometimes we might not, but I always want the patient to know it's up to them. I can tell them that they have a high risk of heart disease, and if they accept that and don't want to take any kind of cholesterol lowering medication, that's still their choice. But I just want them to know the implications, and everybody has a right to the information and to decide themselves what they really want. So I think the most common things we hear are that people have muscle aches and pains, maybe some slight worsening of their arthritis. There is a very, very rare possible complication where there is actually muscle tissue damage. That's fairly uncommon. Some people do complain of memory loss or kind of a brain fog, and I think we need more data to look into that. But the issue is, if somebody feels like that's happening, you have to take it seriously, whether we know the mechanism or not. And usually I'll tell somebody to decrease the medication dose or hold it for a month or 2 and see if they feel better. If they do feel better, then we go back to the drawing table and say, okay, well, this medication caused this, and maybe we can get away with a smaller dose of a different one, or maybe we should try something totally different. Or maybe, you know, these medications are just not necessary for you and the risks are not that high, so you don't need to take it after all. When I talk to patients about lifestyle, I think it's important to acknowledge that I'm not perfect and I'm not doing all the things that I'm recommending they do. I want them to be healthier than I am, and acknowledging that it's very hard to make lifestyle changes. You know, telling somebody to get 8 hours of sleep or to be less stressed or be more mindful, it's really easy to say, but giving them practical ideas for how to actually do these things, I think, is much more important. So for example, if I were to tell a new mom, you need to go exercise 30 minutes a day, that's a pretty hard undertaking for many people, depending on how much support they have. But if I say, well, you know, when you take the baby out, you're going to go around the block 3 or 4 times rather than 2 times, and you're going to use your break at work to take a couple of laps around the building. That's how you can work that exercise into your day without needing to put aside a total block of time. And I think for women especially, who are often worried about taking care of others and carrying a lot of load at home, they constantly have other things that they need to be doing and feel like that's the priority. But our health is important too, and we need to pay attention to ourselves, but it's more likely to be done if we fit it into our already hectic life. I think non-statin therapies are an incredibly exciting area for research that's going on right now. In the last few years, we've found the PCSK9 inhibitors, and that's an amazing find and development for medicine and for cardiac disease, but it's not something that most people need. So I think that statin therapy is still probably pretty good and good enough for most people. There are people who are at higher risk, who PCSK9 inhibitors probably make a lot of sense. There are people who don't really need that, and maybe they just want to work on lifestyle modifications. More recently, bempedoic acid is now on the market. Some people are also worried about the side effects of that. I think it depends on where you are in your health journey. If you're trying to prevent disease versus I've already had a heart attack and now I'm trying to prevent another heart attack, those are two very different conversations. And I encourage people to really consider what is it that we're also trying to avoid? That's a big question. And when we take medications, there's always going to be some downsides. So risk and benefit, I think discussion is really important. The first thing I always think about is, was this true statin intolerance, or was it kind of a coincidence that this person was going through something at the same time that they had started their statin? I always try to take it very seriously, try to find out what the side effects were and what happened after the medication was stopped. Oftentimes we'll try a different medication at a lower dose to see if that gives any benefit without the same side effects. And sometimes we'll just go to a totally different agent, like the PCSK9 inhibitors or the bempedoic acid. I think that people who have had statin intolerance, it does happen, and I certainly can't tell them that it's not happening. So there's some research that maybe being deficient in vitamin D levels might be something that you could address that might help some people with statin intolerance. Giving people CoQ10, at least anecdotally, I've seen so many people who say that they're able to take the statins without as many side effects. So pretty much first line, I tell people, let's try it with the CoQ10. This time, let's do it this way and see if that goes any better. I mean, I think that, the PCSK9 inhibitors are amazing and this, whole new world, but there is a lot of research, especially for people who have familial hyperlipidemia, that is groundbreaking and, still under study. And I think that that has the potential to help certain communities where familial hyperlipidemia is present at a higher rate. I think the bigger issue is what can we do for more people to prevent high cholesterol that would prevent the need for medications later in life, or at least minimize the need for other medications later in life. I think that that's a bigger approach to our food sources and our agriculture and way of life from one day to the next. And that's a little bit harder to do than to take a pill. So although it's not restricted to just cholesterol, there's a lot of data about how air pollution affects somebody's likelihood of having asthma or chronic lung disease. That's been shown with children and their asthma rates. Environment plays a huge part in how a person responds to stress and how often they are exposed to those stressors. So there's research showing that your blood pressure can be higher if you live in a neighborhood that has a lot of noise. So you can't get good sleep. So it makes sense that you're more likely to have high blood pressure, and you have poor sleep, so you're more likely to have poor health. So a lot of these environmental factors, I think, are really playing a bigger role than we might be able to control at this point, but I think we have to start paying more attention to the things that we can do. Even patients in the hospital, there's so much research on how having a calming environment around them, or having something that, looks uplifting or pleasant around them, might help their journey and their healing. And I think that that's true in the places that we live. If we live in a safe, secure community, we interact with it totally differently than if we're scared when we walk out the door. I think what is interesting is the ability to screen more people at younger ages, and even people who aren't coming to the doctor. There are a lot of people who are young, don't really feel like they've got any problems, and high cholesterol doesn't make you feel badly. So if there is easy screening that's available when you go to the corner shop, or you go to the mall. We used to do, at community centers, we would do blood pressure and cholesterol screenings when I was in med school, and those are great opportunities for people who aren't seeing a doctor regularly, can find out, oh, hey, I have this, and maybe I should see a doctor. So I think it's making it more widely available, even when people are not going to come to the doctor and get a blood draw and have to pay insurance for running the blood sample. This is something that I'm hoping newer technology will make it cheaper and faster and more available, and maybe people can check their own cholesterol at home. I think the thing that I've noticed the most about cholesterol management is that it's not a single conversation. It's an ongoing conversation between yourself and the patient, and over months and years, sometimes you can see that somebody is more or less willing to consider a type of treatment than they might have been before. I have patients who, after seeing a family member pass away, they are more willing to try a treatment again. Or maybe they've had grandkids, and for some patients having grandkids, they say, well, now I really want to be here. This is so much more important to me than it was. And now they're ready to really engage in their health again. So I think continuing the conversation, not giving up, just mentioning it each time, even if it's a little bit, and without being judgmental, can eventually get you to the place that you're hoping that they'll get.